I'm really excited to have Sam here as well to cover some of this. We have a bit of time here. Definitely am happy to share the slides. The slides have a lot of links in them, which you are welcome to use to find most of this information online as well. I'm going to cover a lot. What I'm really excited to get to is with Sam's permission, we are showing you the Syringe Service Program client data, which are hot off the press. These are the first data anybody's seeing in the state. These are a bit preliminary, but I think they're solid data that I think are really important added insight along with a bunch of the other data. So I'm going to briefly introduce our center so you know who we are and what we do. Give a quick overview around types of drug epidemiology data. I want to mention some drug checking data around people's supply, talk a bit about treatment data, non-fatal overdoses, fatal overdoses, and then really focus on the perspectives of folks who use drugs from the Syringe Service Program client survey. And maybe I think maybe if there's any clarifying questions along the way, maybe just pipe up. I'd probably not be able to track the chat. Just let me know, and then we can have a little more Q&A at the end with more sort of substantive questions, if that works.
Sorry, can I interrupt you real quick? Sorry. If you are on the line and if you're
Oh, you just muted yourself, Amanda.
yeah, sorry. Just mute yourself if you're not speaking. Thank you.
Ironic, of course. Okay. So I direct our Center for Community Engaged Drug Education, Epidemiology, and Research. We do a lot of different things. We have funding from the Healthcare Authority, from private foundations, from the National Institutes on Health. Our name kind of says what we do. Just noting on the left side, we have a lot of online resources, stopoverdose.org, learnaboutTreatment.org, and a lot of other things really to try to provide information for folks like you who are really trying to strategize and plan and respond. We've been very fortunate to work with Spokane for many, many years. I think you were part of the first wave, Sam, back in 2015 when we first started doing the client survey. So I know we've been coming out there. We've done low barrier buprenorphine, naloxone, drug checking, a lot of different things, and I try to get out there a couple times a year. So I'm happy to see everybody. Very high level, just to share with you around these data. Estimating the amount of substance use is almost impossible. It's a stigmatized behavior, it's a hidden behavior, it's an illegal behavior. So we're kind of trying to figure out the elephant with various senses and trying to come at some sense of what's going on. We often look at phone survey data or maybe who's showing up at treatment. Those are interesting, but they're not representative of the whole population, and they generally underestimate use and severity. Drug consequence data, things like legal involvement, morbidity, mortality, they're complicated. They're a mix both of the actual sort of biology, pharmacology, and medical impacts of the drug, but also our social legal responses, like not receiving care early enough. And so it's important when looking at sort of this consequence data to think about the context. And then drug composition data, what is actually in the drugs? I started doing drug epidemiology 25 years ago, and we had cannabis and heroin and cocaine and methamphetamine, and that's really what we were focused on. And we went from about 4 drugs to about 4,000. So things have gotten a lot more complicated. And we get some data from the state crime lab, from police evidence testing, and a little bit of DEA analyses occasionally. Those are important and interesting, but there's not a lot of context. There's in fact no context generally. And they're often maybe not street level drugs, they're more big buys. And so the interpretation can be a bit difficult. So we're trying to address some of these things. So I'm going to start with our drug checking data. So this is something we've done for about 3 years with folks around the state around community level drug checking and related harm reduction services. We provide the operational support. We coordinate a lot with King County. It's funded by the State Healthcare Authority. We have 8 locations right now, not currently in Spokane. We were in Spokane for a while. We've talked with many different people, and we're hoping to get some going again soon, but we're not doing it right now in Spokane. So I'm going to show you the statewide data. On the left side are drug checking technologies we use in a point of care on site. And so probably people are familiar with test strips, certainly fentanyl test strips. We actually have up to 6 different test strips, which we can use in various combinations to get a fair amount of information. We also use a spectrometer on the left side. This is a pretty complicated piece of analytic chemistry machine, and it can give a much more detailed findings around many, many, many more drugs. It has some important limitations. It's a bit complicated to use. It can't really detect things that are below about 5% of the mass. So if you have a highly potent drug like carfentanil or even fentanyl, it might be present. You might find it on the test strip, but it may not see it on the spectrometer. So we then do, where we can, some complementary testing out of state with mass spectrometry, which gives very detailed analyses. So we're using a bunch of different approaches to drug checking. And the data I'm going to show in a couple of minutes are from the mass spectrometry, the most sensitive, detailed testing. So, but what's the actual process about? Because the chemistry is one piece of this, but it's really about the people. And so these are really around conversations with trained health educators and drug checking technicians. They are going through a drug checking process and discussing the results. They're discussing, well, hey, what are we seeing in the supply more generally that might be helpful for you? And then doing safety planning with that person around their actual results. We never tell anybody their drugs are safe. We never tell anybody that we know definitely what is in or not in these drugs, but it's almost always a lot more information than they had before. And it's a great opportunity for people to come in and talk. We also collect some other information from folks, voluntary anonymous information. Hey, what was the drug sold as? That's a really important lens that's missing from other data. Were there ill effects of the drug? Did they have an overdose, or did they get dizzy, or did they have vision impairment? What happened? And was the drug obtained locally? Very important context. We've seen some strange results. And the person's like, I got this from a pharmacy in Mexico. Great context, but we're not going to issue an alert around one strange drug from something that wasn't purchased locally. Oh, wrong direction. So a little bit of the data, these are data from last year in the beautiful gold color. I'm making fun of purple and gold. I know some of my WSU friends are there. I love you all. What you're seeing here, the gold is what things people brought in to get tested, and the purple is what was actually tested. But you can see by far the most common substance that people brought in were fentanyls. And I say fentanyls because it's not just fentanyl, it's other fentanyl analogs that are kind of similar to fentanyl, and then some that are much more potent, like carfentanil, rarely. And then the second most common is methamphetamine. And the difference here in terms of what people bring in and what's sent for secondary testing, you'll see in just a moment. One of the reasons we see less secondary testing for the methamphetamine is the methamphetamine results are much more generally predictable. So people are less likely to feel the need for additional testing. So I'll show you a little bit about that. So these are the things that were sold as methamphetamine. What happened when they were sent out for GCMS testing? 98% of the time was methamphetamine. And you can see some other additives, this MSM, which is essentially an additive that doesn't have much effect, occasionally cocaine, occasionally fentanyl. This is important, right? You hear a lot about fentanyl in the meth. We are not seeing that in drug checking. I was actually in a clinic yesterday and I saw a scenario where that probably did happen. Like it definitely can happen. This may be a result of cross-contamination in somebody's Altoids container or in a baggie or in a pipe. We don't know that. But generally, the methamphetamine that we are having people bring in is methamphetamine and generally not much else. Very different situation for fentanyl. I'm actually showing you here the somewhat narrower set of things that are fentanyl powder or rock. We're seeing definitely still see blues, M30s, but not as much as we did before. Fentanyl or related compounds, fentanyls, are almost always present. So too is a lot of other stuff. Tylenol, things like lidocaine, strange industrial chemicals. I'm going to come back to xylazine and medetomidine in just a moment. These are very strong animal tranquilizers that we're seeing increasingly. And you can see occasionally we're seeing some of these other compounds like meth and cocaine. I think it's mostly cross-contamination. Hard to know for sure. This one's super important. I want to share with you. This is looking at last year by quarter, what was in things sold as fentanyl. And before you even look at what drugs these are, just look at how much these lines are bouncing around. It just tells you how much the supply is changing. I should also note, this is way less than 1% of the supply. It's not a representative sample. There's no way to do that. So I want to be careful about saying this is representative of all drugs, but it's some of the best data that we do have. So what you see here is this black line decreasing dramatically is this industrial chemical called BTMPS. We still don't really know why it's in there. Lots of theories, but that actually has changed quite dramatically from about 25% of samples to 10%. You can see this green dotted line. There are two of them, but the green dotted line is xylazine, which is a strong sedative. That's sort of stuck around at about 10%. And then another one has come in recently called medetomidine. We rarely see these together. So you can essentially sum those two, 10% plus 11%. About 21% of samples in the fall had either of these very strong sedatives. They can exacerbate an overdose and make it non-responsive to naloxone. And then also medetomidine withdrawal can have some other very serious medical effects that often need to get managed in the ICU. Another line we look at here is this red line, which is no fentanyl type drug, which is, hey, it's fentanyl. Is there fentanyl in it? We generally see fentanyl. It bounces around a little bit. The strong analogs that most typically is carfentanil and methylfentanyl. We see that occasionally, not often. So I put this up here to show you how complicated the fentanyl supply is, sort of why drug checking is important, with important health messages as well, particularly around the sedating drugs, medetomidine and xylazine, which can be really quite potent. You'll also see, I want to note, you'll hear about some of these things like tranq. That's typically xylazine is where that term came from. It kind of could reasonably include medetomidine. Do be mindful when you're looking at around what's in the drug supply of where you're looking. We are not Florida. We are not New York. We are not Boston. So you'll see patterns, and often the national media will talk about this is what the drug supply is like. It varies a lot. In Philadelphia, for instance, I believe they've often been saying medetomidine in 70% of their samples. They have a very different situation there. So just sort of a word to the wise, just be mindful around looking at sort of the source of those types of data about the drug supply. A couple other things I want to go through around some sort of treatment data. This is looking at buprenorphine, the opioid use disorder treatment medication. This is looking at the most recent data from the prescription monitoring program. This is looking at the third quarter of 2025. And you can see the rate for Spokane around coverage is actually higher than the state average, which is great. These are incomplete data. It's actually missing a lot of the long-acting injectable buprenorphine. Obviously, does not include methadone. We don't have the most recent methadone data. And so this is complicated, but it gives you a little sense of, what we're seeing around buprenorphine. And we've been happy to partner with you all. And many of you there are already been doing so much to get buprenorphine available to more people in more places. This is looking at some data around non-fatal overdoses. These are emergency department visits, and you can see these rates here. This is any drug. It's not opioid specific. And you can see the rate here for Spokane is a bit higher than the statewide average. This is the statewide data around drug-involved overdose deaths. Most deaths involve multiple drugs. These are raw counts over a long period of time, and I'll walk through this briefly. So you can see before 2015, things didn't change that much, and the rate was I wouldn't want to say low, but it was lower. And you can see this dramatic increase over the last 10 years that is due to both methamphetamine and or fentanyl. The red line is fentanyl. You can see that coming on strong really over the last 8 years or so, and methamphetamine as well. About 3/4 of fentanyl deaths, about 3/4 of methamphetamine deaths are in combination with fentanyl, but we do see about 1/4 of methamphetamine involved deaths are not along with fentanyl. And I'll talk more about that a little bit later about the so what. We've seen a bit of an uptick in cocaine recently. Pharmaceutical type opioids have been around for a long time, and a dramatic decline in heroin. And you'll see that in the SSP client survey data as well. These are your own data. You're probably very familiar with them, but I just want to show you these data as well. The black line is all drug-involved deaths. I'm going to call it peach. The peach colored line is essentially fentanyl. And you can see back in the day, when I first started doing drug epi, and it's implied here, though it's not explicit, you all have had a lot of methamphetamine for a long time. And back in the day, you were actually seeing more methamphetamine involved deaths than you were opioid deaths, which was pretty unique in the state, actually. You guys had a lot of methamphetamine use. You continue to have a lot of methamphetamine use, but the opioids have come on strong as well. So this is looking at overdose death rates. This is comparing 2 periods. The most recent data that we have in this format are 2023 to 2024. We're comparing it to 2 decades before then. So what you can see here is how much the rate has increased in Spokane. We're now at 42.5 per 100,000 residents. That's higher than the state average of 33. And just also showing you compared to 2 decades before, much, much, much higher rate. So higher rate than the state and a dramatic increase within your county in particular. On the left side here for cocaine, you generally don't have very high rates around cocaine involved deaths. Around the state average, and you've seen about a doubling over this period of time. Methamphetamine, a massive increase in methamphetamine involved overdose deaths, and a much higher rate than you're seeing at the state level. So I will come back to methamphetamine a few times. As I was going through these data, I wasn't surprised, but it really did stand out to me how important methamphetamine is as well alongside of opioids. So now I want to pivot to talk about the syringe services program client data. I'm really excited to share these with you. I'm going to start talking more slowly. I've been talking fast so that I can get to these data. And I think, Sam, please pipe up anytime you want. And then also make sure we'll have some time at the end to sort of talk this through. So the syringe service program client survey data has been done in King County going back to at least 2009. I think before that. We started helping coordinate this in 2015. Spokane has always been a participant. Sharing with you, these are preliminary data. I just ran them this week. We're still doing a little bit of data cleaning, but I thought it was important to share them with you today. These are anonymous and voluntary survey done at the health department syringe service program. Clients get a $10 gift card. Really clear. We are very much in partnership with the local folks doing this the surveying. You all own these data. You can do with them whatever you want to. And if people come to me and say, hey, what's going on with the Spokane data? I will say, go talk to Spokane. They're your data and you can understand them and contextualize them. So I'm sharing these data with you with permission. But I encourage you as well to talk to Sam if you have more questions about these data and want more of these data. We're going to be providing her some more data extracts over the next few weeks. And what we put on our webpage are the state average data, so just to let you know that. And then on the right side, I just have this little call out box here. We do a lot of work in addition to the survey data. We also we've recently done some surveying in permanent supportive housing, including in Spokane. So I encourage you to take a look at that around people's perceptions around substance use and care needs in permanent supportive housing, which is super important. We also do qualitative interviews to really try to understand what's going on behind these survey data. These are essentially kind of a quick 5 to 10 minute survey. We don't have the time to get into a lot of detail, but we get a lot of important insights and things we have more questions about. So we go back and do qualitative interviewing. And then also we have sort of an overview of what these services look like in Washington State based on interviews with managers of syringe service programs across the state, which can give you good insights into the different models and how they're staffed and are they fixed site or mobile and all of that. So that's a little bit about that. I'll mention we have almost 1,700 surveys statewide, which is our biggest number ever, which is a lot. We have 98 from Spokane, which is amazing. That is a lot of work, and I really want to thank Sam and staff there for doing this work. It's a lot of work in the midst of providing services to then also somehow, I still don't know how people do it, pull off doing the client surveys as well. So thank you for that. So start a little bit here with some demographics. The largest proportion of folks were people who identified as white. People could endorse multiple race or ethnicity. The other one that kind of stands out is as a fairly large proportion of folks who are American Indian Alaska Native at a little more than 10%. Housing status, quite striking. This is lower than the state average in terms of the folks who are permanent housed. Only 15% were permanently housed. 52% identified as homeless. 24% temporary unstably housed. This is the first time we've added this column around supportive housing or rental assistance as another type of housing. So we added that as well. The middle piece there in the center is around jail, having been incarcerated in jail in the last year. 51% have been in jail in the last year. That's higher than what we see statewide, which is about 30%. And in terms of gender, about 61% of folks identified as male. So those are some of the high-level demographics. A little bit around usage of the program, injection, overdose, and naloxone. The average number of times the SSP been used in the last month was 2.6 days, so not quite weekly, but almost weekly. 86% of folks had injected in the last month. Very few reported sharing with another person. 17% of those who used opioids had overdosed in the last 3 months. And 90% of all participants, not just those who used opioids, all participants reported carrying Narcan in the last 3 months. And we do think it's very important for anybody coming in and folks who may use methamphetamine and not use opioids to also carry Narcan. They may inadvertently get an opioid or they may witness an opioid overdose. So we really encourage all those folks to have Narcan. Supplies that were obtained there in the last month. Everybody got syringes. Not everybody was necessarily for themselves, because you can see only 86% injected, but a few may have gotten them for a partner or other person. A lot of injection-related supplies. Many people have gotten naloxone in the last month. So where people might have got naloxone once a year, people are seeing so many overdoses and reversing them, they're often getting naloxone much more frequently. A lot of wound care supplies, hygiene supplies, food and drink, and some other sort of basic existence supplies like clothing and tents and such. So a little bit about smoking supplies, interest and potential impacts. Smoking supplies are not distributed by the Spokane Regional Health District, but we still collected these data. 96% of people knew someone who would come to the program if smoking supplies were available. 85% would like to get those supplies at the exchange. And then we asked people here in the lower left, if you look at the pie chart, if you could get pipes or foil smoking supplies, do you think you would inject less often? About 54% said that they did think that was the case. And in fact, there is some nice research that's been done recently that shows making smoking equipment available often leads to decreased injecting. But not everybody said that, as you can see for those results. On the right side, I have the link here, which again will be in the slides. We have a lot about safer smoking supplies. People have a lot of very understandable questions about what are the impacts, what's the evidence. And so we have an information brief that I put together with a student around safer smoking supplies if people have any questions about that. What substances were folks using? So I hate to use the word the winner. I'm not going to say winner. The most common was methamphetamine. 94% have used methamphetamine in the last week. 87% smoked, 78% injected. That number, I quadruple check that number. That is about double the rate of methamphetamine injecting that we see in the state average. So I hang on to that number. That's really important. That's a very, very high rate of injecting for methamphetamine. A relatively low prevalence of folks saying they use cocaine, most people smoking. Heroin, almost nobody reported heroin. It was quite stunning. In the olden days, the majority of folks were coming in using heroin. So things have just changed dramatically over the last decade. Half reported using fentanyl pills or powder. Most were smoking. A minority were injecting. And yet they were still coming into for services there. And I can imagine that's for a whole array of things, probably naloxone among them. And then benzodiazepines were used infrequently. In terms of care needs and use, half of people said they needed healthcare in the last year but didn't get it. I think that's really important. And it's one of the reasons, we did this Meds First study that we did both at the health district and then also compassionate addiction treatment, where we actually offered buprenorphine at the exchange. And part of that was because people didn't want to use, they did want medications, but most were not actually comfortable going to a healthcare setting. And when we asked them why they weren't comfortable going to a healthcare setting, part of it was certainly the navigation, the appointments, managing all of that, but a lot of it was also about how they felt they were treated in very disrespectful ways in those healthcare settings. The average number of times people went to the ER in a past year was 1.15, so most people have been to the ER, some many times. And then in terms of answering the question, would you see a healthcare provider here, meaning at the exchange, 81% said yes. Also really interesting to me, 75% said they would see a counselor for mental health support here. This wasn't among a group who said they had mental health issues. This was among everybody. So I think these are both really striking data there. And then, as I mentioned, the Meds First study, the low barrier buprenorphine study, this is the research article that came out of that. Several hundred people in Spokane participated, enrolled in that project, and were enrolled in the study. And that study found a 68% lower mortality rate among people who got low barrier access to buprenorphine compared to a match comparison. And that comparison was matched by people in the same county, with the same demographics, with the same history of the use of the treatment medications. So it's a very, very fair match. And we still saw dramatic and significant reduction in mortality, not just with the treatment medications, but the treatment medications plus the low barrier access to those medications. And then interest in reducing use. 79% of those using opioids said they're interested in reducing their use, 62% for stimulants. That's actually an increase over the last decade in terms of people saying they want to reduce their use of stimulants. People are often kind of maybe surprised by that, like, well, why is it higher for opioids than stimulants? Briefly, opioids are a negative reinforcer. You keep using to not feel bad. Stimulants are a positive reinforcer. They allow you to function. I'm speaking generally, but they allow you to get stuff done. They might be addressing things like vigilance at night. They might be addressing appetite suppressant. There are reasons that people use stimulants, and supporting folks to reduce their stimulant use generally means addressing the reasons they use stimulants, and the stimulant use actually begins to drop after you start addressing those things. That's different for opioids, where we can get you on medications right now and have an immediate impact, just a very different sort of care trajectory. And I'm going to talk about that with some resources in a minute. So on the left side here, would you be interested? What services would be interested in if they're easy to get for your opioid use, inpatient treatment? Remember, most of these people are unhoused, so I think it's important to remember that. Methadone, 35%, outpatient, 33%, detox, 25, a quarter, 12-step, 21% Suboxone or buprenorphine. It's very interesting. We're seeing this pretty commonly, and I think it really is the dramatic difference with fentanyl and the potency of it and some of the pharmacological pieces of it. There's a lot of interest in methadone. It can be an easier medication to start, and it has a very strong evidence base. So methadone will continue to be a really important resource to have out there. And then what things we're interested in are on helping for their stimulant use. If they're easy to get, rewards program for reducing or stopping stimulant use. My dear friends at WSU are experts there on contingency management, which is what that is actually alluding to. And people are very interested in that. People have very high levels of interest in medications that might help with my mental health and or reduce my use. Just to share with folks, there's modest evidence for medications, nowhere near as strong as for opioids, but they can be beneficial. And most of those medications, many of them, have mental health impacts as well. So then also interest in outpatient, inpatient, and detox. So you can see some of the other interests there. Then this is really important. People who use drugs are people. I think on the outside, we're often like, well, the number one thing in our life must be drugs. That's what they want, that's what they need. That might be true. That might be the most important thing for them. But there's a lot of other supports and services they want. 75% understandably said they wanted help with housing, 61% transportation. This is a new question. The majority wanted help with legal issues, warrants or fines. There are ways to offer not necessarily legal services, but legal navigation services to help support people with those legal issues. Related to that, also help getting an ID that can intersect with some of those legal issues. Half wanted help with employment, and others with insurance and pregnancy and parenting support. So a lot of other things. It's not just about substance use. It's about the other things going on in people's lives. I'm going to quickly go through three other quick things, then I want to come back to the SSP data, but I just want to make sure you have access to these resources around community planning, opioid use disorder, and stimulants, and we'll come back to the SSP data in particular. So I want to make sure people are aware of this document we put out last year. I put this out really because half of the state opioid settlement dollars went to counties, and they didn't really have any materials or supports about how to prioritize how to use those dollars. And so this document is intended to help support that. I know you've got this group, which is wonderful. I hope you're aware of this resource. I encourage you to take a look at it. We'd love any feedback on it. And there's some light facilitation we can potentially help with if it's ever helpful in terms of thinking about a planning process. So I want to make sure you know about that. Hopefully you've already seen this. We printed about 15,000 of them, so we know they're out there. This is a shared decision-making tool for medications for opioid use disorder. This is actually a certified patient decision aid by healthcare authority. So this is a tool to make sure that people are fully informed about their medication options. And then this is really important and likely new to you all. We put this out last year. This is around, it's a shared decision-making tool, but it's not about treatment per se, because our treatments for stimulant use disorder are not nearly as impactful and not necessarily the quick engagement that we see with opioids. So for this material, we're really talking about stimulants in health. How do we support folks in those domains? We start off with some kind of motivational interviewing types of conversation, things around why people use, allowing people to sort of have some insight into some of the cardiac and perhaps cognitive effects that they're having may well be related to stimulant use. They may not be aware of that. We have a lot of information on safer use tips. And then in the centerpiece, there's a lot of things you can do. There's a lot of things you can engage with your healthcare provider about, whether the cardiac issues, oral health, infectious disease, birth control, vaccines, mental health. There's a lot of things you can do to kind of chip away at the reasons that folks are often using methamphetamine. And then specific at the end here around reducing stimulant use, there are medications and contingency management. So we have this one-page flyer, two-sided, that people can certainly use to have good conversations. And on the right side, we have a guide for how to use that tool. So people have some supports in that. And we're very open to doing training. We actually came out last May, I think, and did a lot of training there right down by the river downtown with you all. So I'm going to stop there and stop sharing my screen. And I want to pause, and I would love to get Sam's perspective on all of that.
Thank you.
Real quick,
Yep.
Doctor, there was a question in the chat regarding, did you ask about the interest in what is it, in Sublocade long acting?
Yeah. Oh, did we ask about that specifically?
Yeah.
Great question. We did not ask about that specifically, whether people are interested in Sublocade. Sublocade is a month-long, long-acting injectable buprenorphine. There's another product called Brixadi. But what I will tell you is I spent yesterday at the Orca Center that I helped start in downtown Seattle, and the majority of people coming in are getting long-acting injectable buprenorphine. So I can tell you people are voting with their feet, and they're coming in and they're very, very interested in a long-acting injectable buprenorphine. So it's a very important tool that we know. We didn't ask it in this survey, but I know that from other contexts that people are very interested in that. We also do have oral buprenorphine available there, and we're using something called the 72-hour rule to get people started on methadone in preparation for getting to an opioid treatment program. And we're very excited about that as well.
Nice, thank you. And I didn't introduce Samantha Carroll, so I want to do that now. So for everybody will know that Samantha Carroll is a substance use disorder professional, syringe services coordinator, and an overdose prevention specialist with over 15 years of experience across all levels of care. She currently coordinates the syringe services at the Spokane Regional Health District and continues to work part-time as an SUDP. Sam, thank you for being here. Sorry I didn't introduce you before, but I wanted to get that in. Thank you.
Oh, you're good. I don't have a whole lot to add. It was interesting. That's the first time I'm seeing that information from Caleb from our survey. And shout out to Leilani. Yeah, I know you're on here and you helped with us too. I don't have a whole lot to share. I did want to share just some data about our syringe exchange in general. I don't know. So this is a breakdown of our demographic, our race data, et cetera. Our age data, which Caleb pretty much went over also, but let's see. This is, as you can see though, just the last year, and I want to shout out also to DOH. I think Noah is on here as well. Thank you for putting this together. This was great. We enrolled over 627 people last year. Those are new clients. So that's pretty significant. And as Caleb alluded to, methamphetamine continues to be the winner in the drug race. And most of our people are unhoused. We had 8,974 encounters. That's people that walk through the door to get services last year. 1,000 of those had never been there, were unique individuals. 477 were first visits. So that's kind of a lot of people that we see in a year. Let's see. And also we do have, this is understated, I think, but we do have a wound care service. We have Chaz Medical that comes in on Tuesdays every week. So we do have wound care, some basic wound care for people who need it. We also have testing services and some case management. These are the encounters and how many syringes went out, how many came in, how many Loxone went out. As you can see, quite a few. So we're really happy about that. And it's I'm happy to see that from the surveys that people are pretty inundated with Narcan from getting it here. And these are also some SSP facts about, how many people were tested, et cetera. And I think that is it. Yeah. So I just wanted to drop that data in so you can see kind of the purview of our program. We do serve quite a few people. One of the biggest challenges in our program is people that do want, as Caleb said from the survey, people really do want to stop or reduce their use, and the barriers to doing so are quite high. We don't have any way of testing drugs, so we really don't know what to tell people about when they're asking, like, hey, fentanyl's in the meth, and we really don't have any evidence except for what we're seeing across the state to say, well, that's really not what we're seeing. So drug testing would be fantastic here. One thing I wanted to ask you, Caleb, is one thing that we hear when the pushback about getting drug testing in Spokane is, well, if people test their drugs and it's positive for something, let's say fentanyl is in the meth, aren't they just going to use it anyway?
Sure, they may still use it. I think it's an opportunity though, and the whole point of the health education is potentially use in a safer way, is to use less, is to be with another person, to be in a safe environment, to make sure you have naloxone available, all of those things. So it is not an immediate, oh wow, if I know it's in the drugs, I'm not going to use it. And I think that's important for people to understand, like there's a reason for that. Folks need those drugs in the context of their life, either because they've use disorder or because it's allowing them to function. And so I think that's actually a really interesting window into understanding the lives of folks who use drugs. I mean, imagine you're in a situation where you have this substance, you don't have much money, you really need it to survive, you've been told it might be dangerous. And in the context of your life, that is still seen as a risk that is worth taking because the alternative is worse. So I think it's important to understand what that means, like why that's happening. And so I think it's really important to offer these services. I think there's very little information. It's important to validate people's experiences, actually understand what's in their drugs and that they're correctly interpreting, like, yeah, there's something weird going on here. They also want to share that information with other folks in their community and build up sort of a knowledge base of folks. And then it's really important for you all to see these data to understand, well, what does this mean? What does this tell us about the drug supply? And what are the different types of services that might actually be valuable for folks? So yes, it's possible that folks might still do that. But I also think it's important to understand that that is something that is no longer true for folks who use alcohol or cannabis. They know what they're getting. They know what substances they're getting because of the way they're regulated. But folks who are using drugs that are unregulated don't know that, and it's introducing an extra hazard to them.
Yeah. And I would say for our community in particular, getting medication is really important for folks to get access to that medication. I think that it's kind of a grueling process to get on methadone, as we've all talked about. And we have very few options for same day Suboxone. And I think that that's really the gold standard for helping our community get out of some of this that we're in. So for our purposes, I'd like to focus on that. For the at least the clients that we see, it would be great to be able to send them somewhere right away and say, this is where you can go right now. So that's really all I have just to add to that. And Caleb, if you would you touch on the ORCA program?
Sure. Briefly, just so folks are aware, we've been working for a decade to build up access, in particular around low barrier access to treatment medications, starting at syringe service programs in Seattle and then statewide, including in Spokane. The state is now doing that in a slightly different model called health engagement hubs, which there are 5 of. And then another model is something called the Overdose Recovery Care Access Center, the ORCA Center, which is in downtown Seattle. Now, it's quite unique in that it is open 24/7 and staffed with doctors and nurses, healthcare prescribers, care navigators, and such. I spent the day there yesterday, and it offers these treatment medications on site as well as post overdose monitoring and support. So I was there yesterday. EMS can bring people there either who've had an overdose reversed and or who they may actually have started buprenorphine with, which I believe is now available in Spokane as well. There's a place to take those folks to kind of get stabilized for a while. And we actually were seeing folks also there who are using stimulants who are getting some services and access to some medications and other supports. So it's a newer model of care. I have an NIH grant to develop it and actually test that model. But we've already seen tremendous uptake and very preliminary data from there that for the folks that fire bringing in 2/3 of getting on the treatment medications, mostly long-acting injectable buprenorphine, typically same day.
Thank you. So I just want to read a few things in the chat because there are a couple questions. Jess, they put in there, I have clients opt not to use substances based on testing results, especially when contaminants like xylazine are involved. And then Sean, he put a little link in there about drug testing. It's a link in there. And then Keith is asking, is there any information on people who use street drugs who are dependent on prescription opioids for chronic pain turning to street drugs when they can no longer access their prescription drugs?
Sure. I mean, that's a phenomenon we've been watching for 15 years. I mean, that's something that certainly happened. And when we reined in opioid prescribing, We didn't fully account for the fact that half the people who were dying at that time with pharmaceutical opiates did not have a prescription. This is not a new situation around folks who are no longer able to access opioids that are prescribed to them, turning to street drugs. Just like we see the same thing for people who may not be able to access Adderall who may be using methamphetamine. These are these sort of complicated things that are happening in our society for a bunch of different reasons, whether it's cost or medical practice or concerns about safety, that you're trying to fix a problem over here, and in fact, you might actually make it worse on the flip side.
Thank you. I know I had a question. I sent this one to Sam not long ago, but interested about kratom. Have you got any data on kratom or like deaths on kratom? Like, what's that look like?
Sure. So kratom is a botanical product. You've probably just seen it advertised at every gas station you've been to in the last 3 years. It is an opioid-like compound. I see Dr. Phillips is there if he wants to chime in here at some point. And people can get dependent on it like they would an opioid. And in fact, we've seen people do really well with buprenorphine as a treatment medication for kratom. Interestingly, I will share with you, we did actually ask, I didn't even include the data here. I think we had 7 people who reported using kratom. So I don't know what Sam's seeing. I'm interested in maybe if there's any other providers here from Spokane area. I think we're really seeing a kind of a different market in terms of folks who are using fentanyl versus people who are using kratom. I think there may well be a class or financial component to it. There may also be some of those folks that, as Keith was mentioning, around can't access their opioids for pain, might be using kratom, not illicit fentanyl. So it's complicated what's happening out there. It is interesting though, because there's clearly a lot of kratom use. There would not be all that advertising at gas stations if there weren't a lot of use, right? But we're not seeing it. I'm not seeing it generally within this population. I don't know, Sam, if you're hearing much about that or if there's any providers locally, what they're seeing.
We don't hear a lot about kratom.
Yeah. I will include, when I also send out the slides, we have an information brief on kratom as well. So the other piece on that I will note, though, is that there is a component called 7-hydroxyamitragynine, which is a natural component of kratom, but there are now concentrates that are synthesized. And that is really a related compound, but a very different one, much, much, much stronger. And I know folks in the Poison Center have dealt with some really, very serious and negative consequences due to that compound. I believe there's some state legislation. There's been some federal talk around trying to regulate that as well. So just they're related to each other, but they have some very different ways of working.
Yeah. There is another question from Isaac to expand on Keith's question. Has there been any change in the rate of folks in the last 15 years turning to street sources when prescription opiates are distributed?
I don't know, because we stopped asking those questions. Back in 2009, we asked for the first time, was the first time anybody had ever quantified it. Back in 2009, 40% of people who were using heroin said they started on prescription type opiates. Yeah. And that was more common among young people, actually. There was a point at which that there's so much less opioid prescribing. I think we're seeing the folks who are still alive and are still using, we're still seeing some of those folks who may have started with pharmaceutical opioids 5, 10, 15, 20 years ago. But what I don't know is how much others are people who've been more recently started on prescription opioids, cannot access them, and then are pivoting. We just have not continued to track that. So I can't answer it definitively, but I know that in the states, this is a related question, is the State Healthy Youth Survey. We wrote a question in 2006, 10% of high school sophomores said they've used prescription opiates to get high in the last month. But a decade later, that was down to 1%. So that clearly did sort of get at that issue to some degree. I will say there's another phenomenon, though, that I think is very important. And we've not tried to document it. It'd be really complicated to do. But how many people started with M30s or blues, taken them orally perhaps, and have eventually evolved into fentanyl dependence and injecting or smoking? We don't have an answer to that. I do think that the safety halo of pharmaceutical opioids from 15 and 20 years ago sort of carried over into M30s, these blue oxycodone looking products. And so there's an interrelated sort of perception around those, oh, they're pharmaceutical. And even when they aren't pharmaceutical, somehow there's a notion that it's a pill with a stamp on it, makes it safer. That, of course, is not true. But I think there's still this perception that persists in that way.
Yeah. Well, thank you. Does anybody have any other questions? I don't see any in the chat. All right, well, thank you, Sam, and thank you, Doctor, for coming today. I really appreciate you guys' time. You're more than welcome to stay on and listen, but we really appreciate it. Thank you so much.
Thank you so much. Appreciate it.
Thanks for the opportunity, and I'll send around the slides and also some of the other materials I mentioned. So I really
Perfect.
appreciate it. Thank you all.
Thank
Thanks.
you.
Bye.